Hello, my name is Douglas Konzioka from the Department of Neurological Surgery at the University of Pittsburgh. In this Congress of Neurological Surgeons presentation, I will focus on techniques for stereotactic brain biopsy. There are many elements of performing a successful stereotactic brain biopsy. We will go through each of these from frame application through imaging, setting up stereotactic coordinates, techniques for anesthesia and monitoring, how to create an opening in the skull, choosing the correct biopsy instruments, sampling the lesion, working with the neuropathologist, and postoperative care. Stereotactic device requirements, frame technology or frameless technology, should be accurate, precise, which refers to reproducible accuracy. Many offer fixation so that the target does not move. There should be abilities to confirm the target, and should be flexible so that any intracranial target can be reached and appropriately sampled. All of these devices should be compatible with computed tomography and MRI. When a stereotactic frame is applied to the head, especially for CT imaging, the location of the fixation pin should not be at the plane of the target so as to avoid imaging artifact. Of course, pins should avoid any shunt tubes or bony defects from prior surgeries. If there is a bone flap present, the pin can be placed below the flap or into the flap, especially if the flap is old or if there are titanium plates securing it. Now we'll discuss imaging. The choice of imaging is dependent upon how the lesion is best imaged, convenience, image resolution, and hospital location. At the University of Pittsburgh, we have an intraoperative CT scanner that we use for stereotactic surgery. At most facilities, however, the CT scanners will be in the radiology department, along with the MRI scanners. Most lesions are well seen on CT. Some lesions best seen on MRI are more suitable for MR-guided biopsy. In this lesion here, we have a low-density lesion in the left temporal lobe that is poorly seen on CT and perhaps better seen on MRI. If MRI is used, there needs to be a device to fixate the stereotactic frame in the fiducial box into the more circular cradle of the MR device. In a stereotactic system such as a Lexell frame, orthogonal images, both parallel and perpendicular to the frame, are used to obtain images that are usable for stereotactic coordinate determination. Other systems do not require this. When MRI is used, it is important to check the validity and accuracy of the MR images. In a Lexell system, the distance between the fiducials and the side of the head is 120 millimeters, as seen in this image, and across the frame from left to right, 190 millimeters. It is important to measure these distances to check that what is real is accurately depicted on the MR image. Again, in order to check that there has not been movement from side to side, the measurement to the middle fiducial should be the same on each side of the head. When coordinates are determined using a Cartesian system, the frame center is identified, and the absolute distance into the brain, both left-right for the x-coordinate, anterior-posterior for the y-coordinate, and superior-inferior for the z-coordinate, is measured. The z-coordinate is determined by the presence of the middle fiducial. One measures the distance from the posterior fiducial to the middle fiducial, and generally adds 40 to that number in the Lexell system for the final z-coordinate. It is important to know how each frame system identifies and determines coordinates. In this image on the left, we see a CT scan in a patient with a thalamic lesion where artifact from the post and pins has completely obscured the target. Thus, CT was not amenable to targeting. We then took the patient for an MRI scan, which does not have post and pin artifact, and the lesion can be seen and targeted as noted in the right-sided image. Coronal views for either CT or MRI are important to develop trajectories for safe passage of an instrument from the surface of the brain down to the target. In general, we try to avoid sulci or ventricular surfaces where small arteries may be present. Thus, choosing a trajectory is done in order to try to avoid multiple peel and ependymal surfaces, and to choose a target away from vascular problems such as the middle cerebral territory branches within the Sylvian fissure. For sylvian region tumors, it is best to go medial to the fissure, not through it from a lateral approach. By using coronal and sagittal images, appropriate trajectories can be determined, and many frames have software available for this. The point is to stay within the parenchyma of the brain as much as possible, rather than in the surfaces where blood vessels are located. One software system is the Surgiplan software, which enables the investigator or the surgeon to track the position of the probe as it goes down through the brain. Thus, for this brainstem tumor, which eventually proved to be a lymphoma, one images the medullary target, can determine the X, Y, and Z coordinates in that area, and then images the long axis of the brainstem for safe passage of an instrument down through the brainstem. Although this is a longer route, it is safer than going through the inferior cerebellar peduncle, where more blood vessels of the posterior fossa can be encountered. Thus, in this patient, we did a coronal approach that traverses the ventricle and then into the thalamus. A trajectory is determined to reach the midpoint of the midbrain, not too anterior, not too posterior, to travel through the pons and to reach the medullary target. Here's the coronal approach, entering that gyrus at the top of the head. As one then enters the medulla, we are clear as to where we are at all times, mathematically knowing at which point we enter the top of the midbrain and which time we enter the medulla itself. On the right, one can see a small dot of air within the target after the biopsy, confirming accuracy of the sample. This is a 46-year-old patient with a brainstem syndrome and contrast enhancement within the middle cerebellar peduncle. This can be approached via a transcerebellar route. He also has lesions within the midbrain, as seen in the upper right image. When the stereotatic coordinates are obtained, they are attached to the base ring of the frame, such as here. One can see the Y coordinate of the Lexell frame and the Y bar attached, which holds the Z coordinate. This will then be attached to the stereotatic arc, which will then hold a probe for the purpose of surgery. It's important when the coordinates are set up that they are triple checked to ensure that the correct numbers have been used. Once this is done, surgery can begin. Under anesthesia, it is often that local and IV sedation is best used. And this allows patient feedback to be maintained. For example, if a blood vessel is ruptured and there's bleeding starting, the patient can complain of a headache, and the procedure can be stopped and appropriately managed. Of course, for children, general anesthesia is used. We find that IV fentanyl midazolam, with or without propofol for frame application, is well tolerated. Blood pressure control is very important for stereotatic surgery, and a full bladder, sometimes associated with contrast infusion, can be associated with hypertension. It's best to have the bladder drained and the patient already voided. The best monitoring, I believe, is listening to the patient and asking them how they are doing. It's important to make this as a comfortable an experience as possible. Craniostomy traditionally was created through a standard 14 millimeter burr hole, but in recent years, most people use a small craniostomy, often with a 4 millimeter drill bit, as seen on the right side of this image. The standard array of stereotatic instruments include twist drill devices for puncturing the skin, small 4 millimeter or sometimes 6 millimeter drill bits, dural puncture needles, and sampling cannulae. Most people do use a twist drill. Most do not puncture the dura or cauterize it, but simply puncture the dura itself. Sometimes you will see blood. Most of this comes from the bone. And with a twist drill, it's important to not simply go 1 centimeter through the bone, believing that the average diameter of a person's skull is a centimeter. In fact, I found that the average depth is approximately 6.5 millimeters. I set my depth to 6 millimeters, and I walk down from that point until I eventually just break through the inner table of the skull. Of course, for lateral trajectories of the temporal bone, the bone may be very thin. The skin is infiltrated with lidocaine. The skin puncture device is used to core through the skin and anchor onto the outer table of the skull. The 4 millimeter drill bit is then placed on the skull and the depth guide set to a distance of 6 or 6.5 millimeters. Using the twist drill, the craniostomy is then created. Once we have reached the inner table of the skull, we irrigate out the exposure, and the pieces of bone have been eliminated and removed with the drill bit. We are now ready to puncture the dura. We use a 1.8 millimeter diameter blunt probe to puncture the dura, and then use this to pass down to the target, thereby creating a small tract and sampling the brain on the way down. We don't actually take biopsies with this device, but one can determine if there's any bleeding at any point along the trajectory. It's important always to measure the length of a probe before it is passed into the brain. For the Lexell stereotatic system, the radius of the arc is 19 centimeters, and most, but not all, of the instruments have a functional length of 19 centimeters. Once the dura is punctured and placed down, it can be slowly screwed down to the target. The dural cannula is then removed and replaced with the biopsy cannula. Presently, we use a disposable cannula with an 8 mm side coring opening with a 2.1 mm outer diameter. This is slowly screwed through the dura, down through the brain, into the target. A side coring cannula, the so-called Nashol type cannula, is available with 10 mm, 3 mm, now 8, and even now a 5 mm side coring opening. In past years, some investigators and surgeons have used a pituitary cup forceps design or the spiral cannula. We rarely use these devices at present. This slide shows the different side coring cannulas available with 8 mm openings, 10, and 3 mm. We tend to use a 3 or 5 mm side coring cannula for deep targets such as those within the thalamus or brainstem. The outer diameters vary between 2.1 and 2.5 mm. Sampling the lesion should be done gently. I start with half of cc of suction until I feel a tension. I use a 5 cc syringe hooked to the end of the cannula. I pull back to half a cc, and once I feel that there is a good pull of tissue, this generally means that the cannula is full. The cannula opening is then closed, and then the inner cannula removed and the sample placed onto a wet piece of telfa within a Petri dish. Generally, 2 samples are all that is necessary and given to the neuropathologist who is there. If there is any bleeding, I generally take only 1 sample and have the pathologist review this. If the tissue is likely to provide a diagnosis, then no further samples need to be obtained. Again, the goal of the procedure is an intact patient. Here we take a 5 cc syringe, pull back a half of cc of suction, and then close the opening. The tissue is then removed, placed into a small Petri dish on a wet telfa pad to maintain moisture of the specimen. If there is any hemorrhage seen from the end of the cannula after the biopsy has been taken, we allow it to drip out and we collect it. It's important to ensure normal coagulation profiles before the surgery. If there's any bleeding at all, it usually will stop on its own. We gently irrigate the end of the cannula. We do not cauterize the cannula. We do not instill hydrogen peroxide or any substance through the cannula. It's important to review the images and clinical presentation of the patient with the neuropathologist in order to provide them with the best information possible to allow them to help in the making of a diagnosis. I will always review the tissue with the neuropathologist to make sure that I am happy with the appearance of the samples and helping to achieve our goal of making a diagnosis for this patient. Postoperative care includes closing the skin with fluorochromic suture or fluoronylon suture, removal of the stereotactic frame and placement of a head dressing. In our institution, prior to removal of the frame, we obtain a CT scan. Most centers do not do this, but will scan the patient if there are any problems. We discharge patients home the next day and then contact them either in the hospital or at home with the results of the biopsy, and then appropriate recommendations are made for further consultations and treatment.